am thrilled to be able to introduce someone who shouldn't need too much introduction to this group, but Dr. Nasim Hedayati, who came to UC Davis a little over a decade now, was and remains on the faculty here. Was primarily started at UC Davis, and then 3 years ago now, transitioned to being the chief of vascular surgery at the VA, and really has revolutionized, if you will, the vascular program at the VA, and was part of developing the three-way residency that exists between the VA, Travis, and UC Davis. So I guess you're now senior enough, Dr. Hedayati, to have a perspective to be able to give a talk on the history.
I don't know about that. We'll see. Yeah, thank you.
Thank you.
All right. Thank you, guys. Thank you to all 10 of you guys that are here in person, braving it. I thought it would have been great if I could actually pull out the slide projector for this to really make it truly a historical perspective, but I didn't know if Manny could actually find a slide projector where I could actually do this. I thought Dr. Holcroft would have one, but anyways, but thank you guys for being here this morning. I'm going to talk about, I didn't know what to talk about. As a vascular surgeon, I feel like all the topics have already been talked about. Nobody wants to hear about PAD again or aneurysms. So I thought about the first grand rounds of the year being something to kind of reflect on why we get up on Tuesday mornings and why Dr. Farmer wants us to sign in with these really random EADS codes that I don't know how many comes up with these really random things. Like 58 Imam is just the most random thing I've ever seen. But a couple of disclosures. I have no financial disclosures related to this talk. There's nothing grand at all about this talk, so I hope you guys are not going to be disappointed at the end of this 30-minute presentation. And if at the end of this, you're offended, I apologize in advance. That is not my plan at all to offend anyone with this talk, so I apologize to you guys. So I wanted to kind of talk about a little bit about the history of grand rounds, of why we are where we are and why we have grand rounds to begin with. And talk about a little bit about the role and evolution of morbidity and mortality. Dr. Judge is at the VA right now, and he's been my little guinea pig. I talk to him every day about the evolution of morbidity and mortality conference. So I've talked to him a lot about where we have come from in M&M and where we are now. And kind of try to have, again, it's kind of hard because 110 of you guys are on Zoom and 10 of you guys are here to talk about what the future really holds for our surgical conferences in this era of Zoom and pandemics. So no one really knows where the term grand rounds came about. In the 19th century at Johns Hopkins, Sir William Osler kind of introduced this concept of bedside teaching. So the faculty kind of moved around from patient to patient. They talked about their each diagnosis, and this kind of ultimately kind of moved to this auditorium format, where you can kind of see these older pictures, these physicians, surgeons kind of sat around, and then somebody would talk about a patient in the middle. And I can't, in all honesty, ever look at a picture like this without ever thinking about this. Now, some of you may be, if this comes up, may be Seinfeld fans, may not be Seinfeld fans, but I can never look at that picture and not think about this classic episode of Seinfeld. If you've ever watched Seinfeld, this is probably, you've seen this a million times. If you haven't, I'll let you watch it.
What are you eating? Junior mint. You want? No. No, I can see. Psst. Psst. Good. Get. Yeah. Where'd you get this? The machine. You want one? No. Here. Take one. I don't want it. No, they're good. I don't want it. Just eat one. No, stop. Kramer, stop it.
So that's just
Happy New Year.
Happy New Year. So graduated in 1998 from medical school, and Seinfeld's season finale was in 1998. And I actually, after a medical school graduation, I went to Iran for a month to visit family. Hadn't been back since I left Iran in '85. And the season finale was going to be on while I was in Iran. I had my sister tape it. Yeah, back in the day, there was taping. You guys that have never heard of a VHS tape. So my sister actually taped it for me. So when I came back, I could actually watch the season finale. So back to Grand Rounds. There was a great quote from Dr. Buchwald talking about Grand Rounds. Everyone came to Grand Rounds. Attendance at surgery Grand Rounds was not only required, but eagerly anticipated. By the start of the session, the amphitheater and Grand Rounds were held often that there was no empty seats. Indeed, attendees at times were forced to stand in the back. Grand Rounds took place at a dedicated time held on Saturday mornings from 9 a.m. to noon. They were considered the highlight of the surgical week. And I actually remember as a resident, they were on Saturdays, and everyone came, and there were usually a lot of surgeons that were retired. They would come, and there were a lot of people who usually stood in the back. So, and traditionally, Grand Rounds were really a lot of times case presentations, and the speakers' lectures would turn into these debates and battle of wits, and it was a learning experience, and a lot of times it was a form of entertainment because the older attendings would just sort of battle it out, and they would argue, and a lot of disciplines of surgery participate. Radiologists, pathologists participate, and I remember early on when I even started here, a lot of the interventional radiologists actually came to our Grand Rounds. Dr. Lenk and Dr. Deutsch would come to our Grand Rounds here. A lot of the community physicians would come to Grand Rounds. They would present cases, difficult cases. They would talk about the diagnoses, outcomes, treatments, whether to operate, whether not to operate. The objectives of Grand Rounds, and you guys all know these. I mean, we talk about these because we see them. So we present things that are interesting, latest advancements, medical research. We want to promote collegiality, invite faculty that are experts in their field, talk about things that educate our faculty, our residents, our students, highlight their expertise, showcase our department to residents and students or to applicants that are coming along, announcements, and of course provide CMEs. I don't know if anyone watches Tom and Jerry. My dad loves Tom and Jerry cartoons. There's a classic Tom and Jerry cartoon where Tom is actually trying to stay awake, and he puts these little toothpicks in his eyelids to stay awake. So there have been a couple of Grand Rounds, sadly, I have to say, where I felt like I needed toothpicks. I was going to bring some for you guys in case you felt like toothpicks were really needed for this Grand Rounds. But I thought to myself, what makes a Grand Rounds grand? And I think the number one thing is kind of delivery. Really, it has nothing to do with a topic. So Dr. Jerkovich gave a talk on pancreatic trauma. And that was like one of the best talks I'd ever heard. And I, as a vascular surgeon, was like, God, I want to take my general surgery recertifying exam again just so that I could have a pancreatic trauma question again. It was such a great talk. Or the subject is interesting. I remember Dave Wisner gave a talk about, it was presidential assassinations and what the injuries were. And it was so interesting. And there's a theme here because I think the trauma surgeons have it's like Game of Thrones. They can give a talk about bloodbath and some beheadings and it'll be great. Right? And it's audience interactions and participation. I think we had Justin Disick, who's from Michigan. He gave a great Grand Rounds. We had Dr. Salise from Stanford gave a great Grand Rounds, and there was a lot of audience interaction. So I think those always make for a great Grand Rounds. Exciting new research. One of the things I've always found interesting is that when we've had expert people come, it's been a mixed bag for me. And again, this is where I apologize if I offend people. We've had expert people come from institutions, and I have these high hopes that they're presenting on something that should be so fascinating and interesting, and they throw up a slide, and I just lose interest because it's just the way it's delivered that they completely lose the audience. And I think that's always sad. And then there's always those presentations, no offense, Dr. Former, the accolades in the U.S. News and World Report and the department things where I'm like, this could have been an email. But again, I know we all have to do it and we all will have to listen to it. But I think a lot of it has to do with delivery. And there have been lots of great articles about how do we make Grand Rounds be grand again. And I don't have the answers, but I just thought we could have an interesting discussion about how do we get people to be interested in grand rounds again. So, and you guys all know these things. I mean, over the years, we've seen the reasons for the declining attendance of grand rounds, right? It's sort of the organization, the unappealing topics, and one of the reasons most people have said is that, you know, people have so many other things going on, right? The clinical duties, the subspecialties. You know, in the old days, it used to be most people were involved with the general surgery stuff. Now everybody's so subspecialized. The topics may not relate to you, so you don't have that interest. Inconvenient locations, lack of seating. I don't know if food consumption is really a problem. You know, we drink coffee, there's donuts, not anymore. But so I think those are all the reasons. Now, virtual grand rounds is kind of an interesting thing because we're sort of doing it now, right? So conferences virtually existed before now. It was interesting because I read somewhere that there was 10 million daily users of Zoom in December of 2019, and by April there were 300 million. And that number is probably a lot more now if you consider the fact that we do so many. And that this is not going to get any smaller by any means of, if you imagine in the next 6 months, this number is not going to get any smaller because I don't see us going back to any in-person meetings anytime soon. So what are the advantages? So the advantages we all recognize, right? The increased attendance. I don't know, there was like 118 people attending this right now, I think I saw there. There's a clear economic advantage, right? We don't have to serve food. When you have a visiting faculty, which we had a couple of weeks ago, I think we had a young faculty that was presenting, a transplant attending. So you don't have that increased cost of having to invite somebody to put him up in a nice hotel and take him to a nice dinner. You can still have that kind of interaction with these one-on-one sessions and have other institutions kind of join in your efforts. This I thought this is going to be the most useless slide you're going to see on my talk because of course you're going to have more people attending post Zoom, right? Because somebody can be on the toilet and still be zooming in to this thing because nobody can see them unless somebody didn't, you know, block their video or something. Please don't respond if you actually are. But what are the disadvantages? There are going to be a lot of disadvantages to this too, because we're losing a lot, right? I'm losing the fact that I don't see Dr. Cantor like writing his notes while he's at grand rounds, and that, you know, somebody's on Pinterest or, you know, putting on stuff on their you know, Facebook page or something, or we lose that audience interaction and that you don't have that chance to go up to the speaker after grand rounds and talk to them or ask questions. So there is lots of disadvantages as well to that virtual thing. Kind of going back a little bit now because I do want to talk about M&M too. The history of morbidity and mortality conference, and I want to kind of blend this in with NISQIP and kind of talk about QVU and all this stuff because Sean Judge has heard all my little rants and raves about this. So M&M kind of is really attributed to Ernest Codman because in 1904 he sort of suggested that surgeons should really have some modality where they can kind of report their outcomes, and that hospitals should track every patient long enough to determine if the treatment that they were delivering was actually effective. So he had this vision of what he called the end result system for the hospital. And I love this quote because I think it, even though this was over 100 years ago, it really defines what we do today. He said the system is perfectly simple. The only difficulty with it being its revolutionary simplicity. It requires truthful answers to these questions. What was the matter with the patient? What did the doctor do to him? What was the result? If the result was not good, what was the reason? Was it the fault of the doctor, the patient, the disease, or the hospital organization or the equipment? I claim our record system should enable us to fix responsibility, or it should be used for this purpose, which is exactly what we do now with NISQIP. So of course he did get fired from MGH because he was way too revolutionary for that time. But the American College of Surgeons actually began case reporting of adverse events in 1916. And following that, there was a conference on hospital standardization. The American College of Surgeons established that hospital standardization program in 1918. And then this Morbidity and Mortality conference is really inception paralleled that American College of Surgeons in 1912, and then the institutionalization of medical education, which was promoted by Abraham Flexner in 1910. And then really Codman was instrumental in developing that hospital standardization program, which became the Commission on Accreditation of Health Organization. And this minimum standards was adapted in 1919. This really required the staff to really analyze and review at regular intervals their clinical experience so that you could look at your own complications. And that's when in 1983, the Accreditation Council of Graduate Medical Education made it a requirement that surgical training should have this weekly review of complications. And that's why you guys as residents now are required, or the ACGME requires you to have grand rounds and to have that weekly lectures and courses that are dedicated basically to your education. So of course, this is my shameless plug for the VA and why I love the VA, and I'm so proud to work at the VA, and my husband is a veteran, is that NSQIP really came from the VA, for some of you that didn't know that. In the 1980s, the VA came under a lot of scrutiny because of their outcomes. It was perceived that they had higher mortality than the public sector did. So the Congress passed the Public Law 99-166, which is online. It's 22 pages or 20 pages. You can read it. It was passed in December of 1985. They wanted to address the gap which mandated the VA to report its surgical outcomes annually. So on a risk-adjusted basis to factor all the patient's severity of illness. And this is why in NSQIP now, if you are at UC Davis, you sometimes get harassed by the nurses from NSQIP to make sure that you put down what your patients came in with, because that's very important, because severity of illness really goes into all those equations when they're trying to figure out whether or not you're actually on close to national average or not. And you compare those to national averages. So this initially was called the National VA Surgical Risk Study Group, and 44 hospitals partook that, because at the time, the VA infrastructure actually was able to do that. It had a pretty advanced information system. So when I was an intern, God, I'm going to date myself now, in 1998 at the VA, was it 98? Yes, 98 at the VA, we had CPRS. So the CPRS that you guys use has been around forever, so much longer than anybody else had an electronic healthcare system. So they used that, and the foundation of this work was by Dr. Elisa Iazzoni, who's actually at Harvard. She's a medical doctor who really has dedicated her life really to outcomes research. And she had this algebra of effectiveness, which was basically patient factors and effectiveness of care and random variations equals outcomes. So they used this to really come up with figuring out how to kind of understand, because at the time, really, there were no national averages for outcomes or risk adjustment models to kind of figure out how they could create this model and understand this 30-day mortality and morbidity. So they had a dedicated nurse in each medical center that collected the preoperative, intraoperative, and 30-day outcomes of more than 117,000 major operations. They developed this risk model for 30 days, and then they looked at produced this model, and then they looked at their quality. And for the first time, they had a comparative measure that they could look at 9 specialties. So eventually, this became the National Surgical Quality Improvement Program, and this was actually born in 1914. So over 110,000 major cases were put in this database. Eventually, they had 1 million cases in the VA system, and over time, of course, they decreased their postoperative mortality and morbidity by almost 40%. And in 2001 is when ACS actually piloted this, and in 2004 they rolled it out as the ACS NSQIP, which now most hospitals, I think, pretty much participate in. So the interesting thing was that when this started rolling out, a lot of hospitals wanted to know how their own M&M compared to what ACS actually did. So Hutter looked at, they retrospectively evaluated their own M&M to those captured by their ACS NSQIP nurses. And it was interesting because the death rates were different. So the death rates that they captured at their own M&M conferences were significantly different from the NSQIP stuff. And it had to do with the fact that sometimes when we have patients that go in hospice or they die on a medical service, or if they were deemed non-operative because they had, they opened them up and they said this is non-curative cancer. They closed them up and said this patient's going to die. They just didn't capture that death in their own M&M, but NSQIP did. Because remember, NSQIP still captures that death even though they died, somewhere else. They're still going to capture it. I mean, they're really good. I mean, even at the VA, our nurses will say, well, this guy went to another hospital. We captured that, and he died there, even though we don't know that. So, and also when it came to complications, the complication rates, they were reported at 6.4%, but NSQIP captured at 28.9% because there were things that the department said, well, this is kind of trivial. This is not really a wound infection. But according to the way NSQIP had defined it, it was actually a complication because there's things we consider, oh, that's just part of the surgery, or this was a little red, I put them on antibiotics, but that's really considered a complication. So I think that has, to me as a vascular surgeon, I think the way I've sort of looked at NSQIP is that it has made us better surgeons in the sense that we go back and look at our data and say, how do we make this better? If our DVT rates are higher, how do we make this better? Are we using enough DVT prophylaxis in our patients? If our MI rates are higher, are we making sure our patients are on aspirin or a statin? So I think it's been, overall, I think most people would agree that it's been able to help us be better surgeons. So the value, I think most would agree that the M&M conferences as we have it, and this is what I kind of wanted to kind of focus on that second half of my talk, is sort of be considered a powerful surgical education tool. I think most papers on the value of M&M conference is that it universally accepted by faculty, although faculty and residents have sort of traditionally have had differing views on it, and it's changed a lot in format over the last 10 years that I've been here, is that it's educational. It helps us reduce error. It's sort of a quality assurance measure. It helps us learn how to manage complications and hopefully improve patient care. And the ways that we can improve it is sort of better participation, maybe interesting cases, being more open and less defensive so that we don't take things very personally. We use literature and less anecdotes. Although I have to say, sometimes anecdotal stuff, like when Dr. Djokovic says it's right-sided and everybody else says left-sided, it's helpful, right? Because it's also that experience of surgeons that say, look, I've done this 100 times. Go give me 100 papers. I don't care. I've done it this way, and this is my experience. That's helpful. I don't think we should lose that completely by saying, oh, look, I found 5 papers from random journals, and this is how it should be. I think that anecdotal surgical experience, I think, is still very helpful. And it does encourage residents to read more. And I think that's very valuable. I think one of the things that is crucial about this, and I think some of you may have read Forgive and Remember, which is a classic book by Charles Bosk about medical errors, and he sort of classified medical errors in 4 categories, and this is not something I'm asking you to actually, most people probably wouldn't agree with this concept, but he sort of classified into technical, judgmental, normative, and quasi-normative. Technical and judgmental being decision-making errors that could be forgiven, and the other 2 being inexcusable and blameworthy that could not be forgiven. But he sort of used this term of putting on the hair shirt. It's sort of like the self-punishment, right? That by admitting failures in morbidity and mortality and saying, look, I did this, I shouldn't have done this, or I should have done it differently, you're actually turning something negative into positive and garnering, support from your colleagues. I think one of the things I always remember as a resident when I had done something that had led to a complication, I always remember one of the pediatric surgeons telling me, good judgment is a result of experience, and experience comes from bad judgment. That's one of the things we remember, because that's sort of like the basis of really M&M, is sort of we learn from M&M of what things not to do next time or how to do things differently, and that's really the basis of it. So, a few years ago we had Tim Lean from Ohio State come and talk to us about this. So their group with Erica Mitchell, they had developed this communication tool to improve resident presentation and education, to standardize, the M&M conference data entry, and they use this SBAR technique, which is a situation, background, assessment, and recommendation. It's something that's got an accessible database. The residents know this way too well. And you can document all this stuff with practice guidelines, and it's available for CME and maintenance of certification. Again, the situation is, you state what the problem is, you have the background information about what the adverse outcomes are, then you evaluate it in terms of what the errors were, you review the literature, and then you make some proposal of what the actual thing is. So Dr. Jerkovich is actually on their website. If you've never been on their website, the guy actually does look a lot like Dr. Jerkovich. QView assists me and my team in providing a standardized approach to identifying system problems in a privileged and dynamic manner, allowing for standardization of the M&M conference to create a pathway for improved care. Kelly's actually on there too. I didn't put her quote on there, but and this, of course, you guys all use it for your M&Ms and stuff. So the current M&M, sort of to me, of course, I got a different view of it today before I had presented prepared this talk. The resident inputs all this information. He or she presents all these complications. They're given a topic ahead of time to present. One hand goes up, although today there was more than one hand that went up, and I'm very proud of myself for coming up to the mic. And then there's some discussion, and everybody just pats everybody on the back, and then the next complication gets presented. And this, I'll explain why I'm going into this. And then it's all big data, right? So why, grandma, what big data you have? So I'll tell you how when I was a resident, how this all happened. This is here I am. This is our chief here with Dr. Ponsky, who's our department chair. This is our chief. We always took a picture when we were chiefs. So when we were interns, we sat in the back. So all the interns sat in the back. We watched our chiefs. They either conquered the audience or they went down like the Titanic. And it was just like, what you learn is that if you mentioned anything, you better own it and you better know it. So if you mentioned a grade 3 liver laceration, you better know all the grades because you were leading them down that path. And then what you learn as a chief is that every decision we made at the county hospital was always like, how am I going to justify this to Dr. Malangoni? Because Dr. Mark Malangoni, who was very involved with the American College of Surgeons, American Board of Surgery, we were so deathly afraid of that if somebody wasn't on sub-Q heparin on rounds, and you would find out as a chief, the intern's head would roll because we knew, God, if that guy got a DVT, Tuesday morning was going to be brutal. So, and all the chiefs had extra clothes in the call room because you never dared present with scrubs. So one of my chiefs, when I was an intern, told me when she didn't have actually dress clothes, she had actually pulled her scrub pants up high. She had her lab coat so that it just looked like she had a dress underneath. So she didn't want to present in scrubs. So it just looked like she had bare legs and her Crocs or whatever she was wearing, and just, her scrub top there, and she had buttoned it all the way up. And it was really like being peppered for oral boards. Anything went. You got questioned on pretty much everything, so you knew every detail of that patient and what complication they had. And the most important thing was that you looked at Dr. Preby, and this is Dr. Preby. I love Dr. Preby. There he is. He never wore a white coat. He always wore a suit. Did Dr. Preby move in his seat? Because if he had moved in his seat, you had just piqued his interest by saying something incredibly dumb or that somebody else did something that he disagreed with. And we loved operating with Dr. Preby, even though he was so hard. But you know what? He was a really awesome surgeon. People transferred disasters to him all the time. People with 20 fistulas coming out of their belly, and all the other surgeons always called them when they needed help. And he was a hard ass, but you know what? We loved operating with him. So that was like my experience with M&M as a resident, because it was really getting prepared for oral boards. There was none of the, here's a paper I want you to present. I want you to present on subclavian, presentation. It's this nice, cozy thing. Warm and fuzzy, it wasn't. And it was a different era, I get it. But it was a way to really prepare you for oral boards, because anything went. And if you went up there. So my thing, as you can see, I talk really fast. So I talked really fast and I told them everything I knew. So one time, one of the attendings told me I took the fun out of M&M, which by my standards, that was fine by me, because then I couldn't get peppered too bad. So this is me at Baylor Fellowship. This is Dr. DeBakey. So Baylor had its seating hierarchy in the conferences. So the front row was the Legends row. So that's where Dr. Maddox and Dr. Cooley and Dr. McCullum and Dr. Noon sat. Dr. Noon is actually the surgeon that operated on Dr. DeBakey when he was 98 and had a dissection. And then the senior faculty sat behind him, and then the junior faculty and the fellows and the chief residents and all of that. So the current M&M format, this is Dr. Pevick. So this photo is courtesy of Dr. Baker, Aaron Baker, who is a former resident. He sent this picture to me, and I actually called Dr. Pevick and I said, can I use this photo? And he said, you can't hurt me anymore, so go ahead and use it. So, and I really wanted to actually poll the residents about their experience with M&M, but I didn't have enough time, so I apologize. So, and I recognize that we do have a lot of divisional M&Ms where the residents do get questioned, and it is a lot more uncomfortable for them. So, I wanted to kind of open this sort of for discussion for us, is that a couple of questions for us to kind of discuss is sort of how do we capture, one, the grandeur or splendor of grand rounds in this age of virtual grand rounds, and how do we improve participation? And then the other thing is, can we go to some format of developmental, morbidity and mortality conference where, we sort of demanded that mastery of the clinical knowledge from the residents and sort of blended it in with this, what we require now from the residents is this revolving door of big data and fishbone diagrams, or can we do both? Or maybe the residents are like, fishbone is fine, don't bug us with this other stuff, we don't want to be pimped. I don't know. I'm interested to hear what everybody's thoughts are. So, and that's it. And those are my triplets. He was a scary banana this year. And my daughter's dressed up as grandma. She actually picked up a grandma costume, and he's wearing his mask actually. And he was a dragon, and he had a bloody knife, but I don't know what happened to the bloody knife. So.
Well, Dr. Hedayati, as always, you are an excellent presenter and keep the audience engaged for sure. So thank you for this.
Thank you.
This has been an ongoing and active conversation in the department for a while. The fishbone diagram, we can actually credit to Jamie Anderson, I believe, who, when the question of what to do with M&M and grand rounds, and this is, we've changed the format, as you know, over the years several times in response to a variety of input from residents and faculty, and it's a really interesting question about how to balance now in the large department subspecialty interests and others. I very clearly remember, since you mentioned Dr. Cantor, hi, Bob, when I made grand rounds mandatory.
Yes.
I was struck with the fact that it was pretty low turnout. And particularly the plastics and cardiac colleagues at the time made a comment, this doesn't have value for us in college animal surgery, et cetera, except then there would be an incredibly interesting complication on a different service that benefited from plastic surgery input on how you might manage this complex wound, or cardiac involvement. I remember about the woman who was saved with an operative extraction of a giant pulmonary embolism in the operating room. That people had forgotten that was a possibility as a way to rescue someone with an acute problem. And so forcing the cross-fertilization, I actually think is more important. That's just my bias. Now that we are so subspecialized and siloed, we read our own literature, we self-promote. So that's why I thought it was an important thing to do. M&M, I do think you raised some incredibly interesting, important comments. surgery is still an art. You're good at what you do, and you need to know your own limitations. And I definitely do not want Dr. Jerkovich putting in a left foot plate. Even though I think he's wrong, I mean, we had to joke that, I trained in Seattle and he trained in Denver, and that's where I was told and taught that the left was the proper side. And in Denver, and so but that's his experience. I'm sure he's better at a right than a left. I can tell you I'm better at a left than a right.
It's the elevation.
There's lots of things. But we all need to learn ultrasound. That's a case. The other role, I think, of turning M&M into a teaching conference is to try to pick things where you hope, by hearing about this complication, instead of 10 people having to do it and injure 10 patients, you can absorb something that will prevent you from having to learn it the hard way, although most of what we have to learn is the hard way. Mm-hmm. So thank you for this incredibly provocative presentation this morning. So, Dr. Gagansky, what do you have for...
I just wanted to add a comment from the resident perspective. I've always found the M&M process of preparing them and learning from others very educational. And I have to say I'm a little concerned when the attendings are presenting an M&M, just because it's another opportunity taken away from residents to learn what the important parts are of that operation, learn where the error was made, but also just that skill of presenting, right? It's the skill of presenting for oral boards, being concise, learning the pitfalls and how to answer questions on the spot. So I think it should always be the residents. Personal bias, I can't say that's the opinion of all the residents, just because we have to learn how to do that too, because that's going to be us in a few years.
I do think, one of the things the department's very proud of, and has been for a long time before me, the excellent board pass rate. Mm-hmm. UC Davis has one of the best both written and oral board pass rates in the country, and in California as well. But and we have felt that forcing residents to, not forcing it, this is the right word. Encouraging residents to present and the mock oral boards and things like that. Dr. Jerkovich, you really revolutionized and led this process over the last couple of years.
Well, I share all of the concerns and questions and background issues that Dr. Hedayati has brought forward to this conference this morning. The conflicting priorities are very real and are very hard to balance, whether it's from the hospital administration side of the quality issues that they care about, whether it's from the American College of Surgeons tracking issues which they care about, whether it's from their conflicts of time and how much we have available. But I think those are all manageable. I think that the biggest struggle falls in the issue of trust within ourselves, within our departments. There are many who are continually afraid to present because they feel the criticism is unwarranted or unjustified, or they're afraid of it. And as long as that happens, in the absence of a very strict hierarchy, which was the historical perspective that you put on, that culture of a very strict hierarchy, remove those blocks and said, I don't care if you're upset, tough. But without that, it matters that the department has within itself and within all of its faculty a trust and a willingness to bear the hair shirt and present their flaws and feel that others can learn from and they can be accepted for their complication by others within their peer group. The lack of that leads to the kind of conferences that you're decrying in the talk, which are those that lack any of that sort of straightforward ownership, responsibility, shows an inability to present sort of the worst of complications. And that, of course, what Codman was railing against. I mean, that is what he did not want to have happen. And that is, you're 100% correct, Lisa, I agree with that he's given a lot of credit for founding the concept of ownership, and that's the historical perspective we have. So all of these together are a number of different competing interests that we try to balance, and really appreciate you bringing many of them forward today, so thank you.
And my point of view was not at all I completely agree with, I think having the script and all of that, I think is crucial to who we are as surgeons. And I'm not at all saying that we shouldn't have the modalities that we have to track our own results and figure out the pathways that we have. And and when I came here, Dr. Goodnight, who was our department chair, I sort of felt like, oh my God, he's the nicest chair that we have. And he has really, the department that he has created is the most collegial department. And I've never at any point felt that this department was a place where people, felt like they had to, it wasn't the East Coast, Midwest kind of mentality of what M&M was. Yes, Bill, and I love Bill, and he's a dear friend. Yes, he brought that on. He wanted to, kind of stir the pot sometimes, but that's how he taught. I mean, that's how he taught the residents, asking them lots of questions. But I don't think the concept of, like, if you bring up questions or ask questions from another division or bring up things, I think has to be taken with a grain of salt. I don't think it's ever in a sense to insult another service or anything. It's all meant in the point of trying to learn from each other and to work collegially. I don't think of it as ever like asking, why certain things happen and stuff. I don't ever consider it that we are like, and maybe I'm just the only person that thinks of it. Maybe other people get offended by things, but if somebody else asks me, why did you do this or that, and, I can justify it. But, I certainly wouldn't want other people to feel like if we question each other in a format like this, I would hope that we're beyond that we don't get offended and we could rise above that and say, you're here to learn from each other, and at the same time, we're here so that the residents can learn from us, because that's what we want them to learn from us, that we can work collegially and learn from each other's mistakes. And that's, I don't know if that makes any sense, but
I do think we looked at this, that about somewhere around 10% of the programs have eliminated M&M. There's a multidisciplinary M&M. UCSF got rid of it when I was there. They only have their divisional M&M, and that the institutional quality work, which is sometimes our fifth Tuesday or our second Tuesday, is done in that setting. And the chiefs have a separate quality meeting where they go over all of the problems that are in Cuba and reported to the hospital, and to satisfy that hospital quality part. We thought there was some educational value, particularly for residents, chief residents, for going into training to realize someone is going to watch everything you do.
Yeah, no, of course.
And how you are trapped, and just to learn that by looking at that process, and that they're going to look at all your M&Ms. So we've got two more questions. We'll start in-house, and then we'll go online.
I just sort of have two-pronged comments, one for Grand Rounds, one for M&M. So first of all, thank you for bringing this up. I loved your talk.
Thank you.
Some of my best memories from here were when we hosted Dr. Lilimo and Dr. Scalia for the Fry and Battistella lectureships. Like, those were so memorable, and they were amazing. And I'm going to, carry that in their talks with me. And I'm so glad I got to meet them. And that's just something, those mornings and that feeling and the, breakfasts, they're just never going to be replaced in the virtual format. And I hope that we can get back to that one day. I was talking to one of my interns on the trauma service about what Grand Rounds and M&M used to be all of 10 months ago. And I was like, everyone was there. People sit on the floor. You eat breakfast. When anesthesia comes, we get eggs. And he was just, he was looking at me like this was just completely foreign. I was like, wow, that happened so quickly that experience was lost. And I thought it was really sad. In terms of M&M, I think... I completely agree with Dr. Farmer's point that it brings us out of our silos, which, 5 years of clinical residency with how specialized everything is now, anything that can enhance our learning experience of thoracic, vascular things I don't spend a lot of time on, I find really valuable. I also, we had this saying in the military that adult learning comes from repetition or blunt force trauma, and I think presenting one of your mistakes falls under blunt force trauma. And the M&Ms I've had to present, there was one I worked on with you, and you said, it'll put some hair on your chest, but you can do it. I'm carrying that patient with me forever as well. And then my last point is that as I work through the question bank for ABSITE, especially trauma, you guys are I'll get to a question, it's like, how would you manage this patient? I'm like, Dr. Schatz would do A, Jerkovich would do B, Kokonara would do C, and I love hearing those kind of patients brought up here and hearing their dialogue with each other as opposed to just hierarchically down to me, but having that crosstalk. And that's not going to be replaced by big data. That's going to be right versus left, or whatever. Okay. So no real questions. Those are just my thoughts, but I wanted to share.
Thank you. That's great.
Dr. Cook had a question kind of along the same lines as your point, Dr. Farmer, about quality improvement. His question is, what are your thoughts on if Department M&M should be considered quality improvement or education? QI is often a more detailed case review of all cases.
I think the way I sort of gather from the way the residents have described it, I think M&M is sort of really educational, but it does blend itself in for the quality improvement as well, because you're the way I sort of understood it, and the more I sort of looked at the Q-view, the purpose of it is for us really to capture the types of complications, so we sort of can look at it and say, look, we had so many central line complications, we had so many missed opportunities or delays to the OR, so that we can look at it and say, how can we improve this in terms of policy or things like that. So it's sort of I think it's a combination of things.
Yeah, I agree. I think I made this comment last week, even, that one of my complaints or concerns about the way hospital quality and Vizient quality is collected and the data that they look at, that they have to collect what's sort of easy to collect. Hospital site sections. The nurse can walk around and look at all of those things and collect it. But what matters to a patient is whether their disease has been cured and their function has been restored. And they don't really care how damn many days they stayed in the hospital to accomplish that goal. And if they had stayed 3 extra days, but that means they're going to walk for the rest of their life, I'm going to ski again after my ACL repair. Yeah. I don't care if I stay in the hospital a month. If at the end of it, I get the outcome. So how do we get both of that? And I think we as doctors have to maintain, because no one checks it. No one checks if you actually cured your patient of cancer. No one actually holds you accountable, and it's hard to evaluate whether or not that positive margin could have been not a positive margin, and what the outcome of that was going to be. So we have to look at both. We have to acknowledge that the hospital cares about this other stuff, and that's how we're going to get paid, and it's going to affect a whole lot of other things. But we also have to make sure that the kid with esophageal atresia gets a good enough operation that they can eat on their own and swallow for the rest of their life, as opposed to be fed through, a jejunoscopy forever. Because you've got one shot at getting that right. So balancing that, I think, is our job. That's why surgery is still an art. That's why there's the right and the left. And that's why the moral responsibility of doing the right thing for the patient is still going to rest in the doctor. In my opinion, it will never be replaced by a hospital quality program. But we need both. Not that one is more important than the other. We need both to have a robust system. Thank you, Dr. Hedayati.
Thank you.